you. We're getting a bit nearer to that cup of tea, coffee break. So I'm going to talk about how we measure response to treatment and talk a little bit more detail about the PCR test, what it actually involves, the time points at which we should be doing PCR testing, and overall how it helps us treat CML effectively. So the principles, as we've been talking about, CML's caused by this fusion gene, BCR-ABL. So a key point at which we can use PCR testing is at diagnosis to identify that that BCR-ABL gene is present. And that gives us 100% confirmation that we know the diagnosis is there. Following on from that, we can look at the levels of the BCR-ABL gene by PCR. And this gives us a readout over time of how the leukemia is responding to treatment. The PCR test is hugely valuable because we can get so much information from blood. And this now means we can perform far fewer bone marrows, which is a huge relief for patients. And the PCR method is very sensitive. We can now use it to pick up much lower levels of CML that may be left behind compared to bone marrow techniques relying just on the cytogenetics. So PCR is the polymerase chain reaction, and it's a laboratory method using enzyme reactions, focusing in on just very small quantities of DNA, specifically this BCR-ABL area that we're interested in, to give us a result that we can measure. And that answer, that result may be a yes or no in diagnostic terms at the very beginning, or we can get a figure, a number, that enables us to follow response to treatment. And PCR is a combination of people, very skilled laboratory technicians in a team, and it's also highly automated. It can sometimes fail, and I imagine most of you at some point or other have come to clinic for a result and just been told we didn't get one this time. And these technical failures will happen from time to time. They have no meaning in terms of disease response, and it simply means we just need to repeat the test. It's important that the PCR tests are highly standardized so that I can talk about how my patients are doing in comparison to Joe's, in comparison to Mary's, in comparison to colleagues internationally, and we're all talking the same language. The tests are batched in order to help with economies of the cost of the reagents and the time of the technicians performing them, and that works out in our hands at around £90 per test. So this slide is talking us through the process. It starts at the beginning with the samples coming into the laboratory and the vital stage of careful labelling. It's obviously important that every result we get is attributed back to the correct person. So then we start with the blood in the test tube, and these cells need to be lysed or broken open to get the genetic code. We start off with the RNA, which is a translation of the DNA code, and this is extracted and stabilized. And then we use enzymes to work a step backwards, back to that original DNA instruction manual, and use sets of enzymes to focus on the BCR-ABL, and then to increase the numbers of this over and over again in this chain reaction process that enables us to detect very low levels. So in practice, this is a lot of samples in these little plastic Eppendorf tubes, batched together, so again you can see how vital the careful labelling needs to be. These are loaded on plates into the PCR machine, which takes them through cycles of different temperatures. The results are compared then with standard curves to give us a number, and the laboratory technicians and scientists then analyse this into a report for us, which gives us our readout over time. And these are our Leeds HMDS reports that look like this, that I will talk you through. So PCR monitoring is now fully validated and recommended as part of our care of leukemia, both in the European and the American national guidelines. And as Joe has said, we're looking to work through these levels of response in the leukemia cells. As the number of cells reduce, we're looking to work through these stages, first of all, of normalizing the high white count, then of getting rid of this Philadelphia chromosome, and then these deeper levels of response. We used to only be able to see really what was going on behind the scenes by doing bone marrows and seeing if the Philadelphia chromosome was still there. But now we can look at a lower level by using this PCR test. So some maths now, and the graphs we look at are plotted in a different way to what we're used to at school with 1, 2, 3, 4 up the side of the graph, and we talk about a log scale. And this is a little bit hard to explain. It's essentially looking at how many times we're multiplying by 10. So picking an easy number to start with, 10 times 10 times 10 times 10 times 10 times 10, 6 times over, that's 1 million cells. This is 1,000 million and 1 million million cells, and that's our sort of starting point in treating CML. And at that level, 100% of cells will contain the Philadelphia chromosome. Then as we come in with our treatment, that level starts to drop down, and when we've gone down by a power of 10, we know that this equates to removing the majority of the Philadelphia chromosome, perhaps around a third is left. And ideally, we like to see that at 3 months, which we call it optimal response. As the imatinib kicks in, then the Philadelphia chromosome reduces further and should disappear altogether. So as we go down by another power of 10, by 6 months, we're looking to have this complete cytogenetic response. And by 6 months, when this disappears, it will mostly never be detectable again. As the number of leukemia cells, however, continues to reduce, the efficacy of the treatment continues. So now we add in the PCR measurements, and these are percentages. So our starting point is 100%. And then as we drop down that first level, 10%, 1%, and then starting to get more and more zeros behind the decimal point. That's always what we want, a 0 behind the decimal point. And we can see that this PCR technique is now letting us look at these sorts of levels, whereas by the cytogenetics, we really couldn't find out much further than here. So this graph looks at time along the bottom axis, the number of years since starting treatment, and the levels start to drop, and we aim for this 10% level major cytogenetic response at 3 months. We know these are equivalences that have been tried and tested and are reliable. As we move further down, complete cytogenetic response or a 1% level at 6 months, we now often don't do a bone marrow to prove we have cytogenetic response. We rely on the BCR-ABL level of around 1% being a good surrogate marker for that. And then moving down into major molecular response. And this, as we've been talking about, is our safe haven. That's where we know the chances of the leukemia progressing and making people unwell are very, very slim. We're getting more and more interested now in the lower levels of response, and we now look at the lower levels of the graph as we move down by a power of 10 and a power of 10 again. And we label these as MR4 and then MR5 as we drop down further. And these lower levels we call a deep molecular response. So this graph really gives us the same information, just concentrating on these early milestones that we like to aim for. We know the patients who hit these milestones do particularly well. So over time, we continue to monitor carefully, and in the main, at this point, we're looking to see if something could be changing behind the scenes. The white count remains normal, the patient may remain well, but we're looking for any early marker that might indicate that things are not going well. And this can occur due to a mutation, meaning that the cells are no longer sensitive to the drug, or perhaps a patient has had to interrupt their drug, maybe due to side effects or other illnesses. So a rise in the BCR-ABL PCR could indicate that there is resistance and the patient could be heading towards a relapse. This is unusual, only in a minority of patients, and it mostly occurs quite early on. But by detecting this early by the PCR technique, we have the opportunity to intervene and potentially to change therapy to get back on track again. So another molecular technique that we use to look in more detail is sequencing, and this is reading the DNA code to see if anything has changed. And mutations can occur in the DNA which change the whole meaning of the coding. So this is an example of the T315I mutation, which is very well described in CML. And the process of changing just this G base to an A base, like changing one letter in a word, can change the whole meaning. And this means that the BCR-ABL is no longer sensitive to most of our drugs and requires a switch of therapy to ponatinib. So lastly, just some pictures. Pictures speak 1,000 words, and I'll talk you through some graphs of some of our patients. So these are our graphs that we look at in Leeds, and I like to always show my patients the graphs in clinic, so we look at them together. We've got the BCR-ABL percentages up the side, starting at 100 in the red, moving down through the percentages, 10%, 1%, major molecular response at 0.1, and then these areas where we get the zeros behind the decimal point that we're happy with, we colour in the green, and then time coming along the bottom. Ignore the purple labels. So this is a patient who was started on nilotinib at diagnosis and has had a really rapid response. So we can see over a matter of 6 months, they've whizzed through their milestones and they're already in major molecular remission, and that is continuing to deepen. Happy days. But it doesn't quite pan out that way, obviously, for everybody. And this is another graph of happy days. It just took a lot longer to get there. So the difference here is the time along the bottom. This isn't months now, this is years. And this is a patient in a trial who was on dasatinib, and it took a lot longer to come down into the green. And I think the other important thing about this graph is to see the flicks. This flick was when the patient had to stop their drug for a while and then went back on. And I think this illustrates quite nicely how we mustn't get too tweaked or upset by one value, because just one value in isolation might look concerning, but the next value may well be on track again. And we do need to be patient, look at patterns over time, get the pattern of results established, because fundamentally, so long as you get there, and it doesn't always mean that it's critical that the early milestones are met on time. So just putting those two graphs together for comparison, we can see the very different timescales, but both patients extremely well and in a safe place. This, of course, is the other side of the coin, and this is a patient who's not responded to treatment. They started off on imatinib, switched to nilotinib. We then found the T315I mutation, switched them to ponatinib, and unfortunately no response. So this patient is going to have a transplant in the next couple of weeks. And this is another pattern that we see. This is quite an elderly patient who didn't respond optimally to treatment at the beginning, was switched to nilotinib, felt fantastic on it, felt so much better, and the levels started to trickle down. So we were happy, we were watching this, and then they stuck. And we did have debates about changing perhaps to another drug, and he felt so well on this drug and had quite a lot of side effects from other types of medication. He was very clear he wanted to stay put, thank you very much. And these levels have just flicked around this, just under 1% ever since. We did a bone marrow. We know that the cytogenetics are fine. The Philadelphia chromosome has gone, so that gives us a level of security. We know this isn't the safe haven, and it's possible for patients still to relapse. But really, as the more years have ticked by, we do feel that this patient is adequately treated. So being in the green is always desirable, but it's not always essential. And lastly, this is the graph of a patient who's in the Destiny trial of stopping treatment, which we're going to hear a lot more about. Obviously had a very good early response to treatment and lots of values tucked down into this MR4 lower level. They stopped their halved their treatment and then stopped their treatment on the trial. And he wasn't one of the lucky ones, and the levels started to come up. On restarting imatinib, safely back down again. So why is PCR helpful to us? It's very helpful at diagnosis, giving us precision. Early PCRs that we've spoken about can give us an indication of how well patients are likely to respond. It gives us some numbers, some quantification of how patients are responding over time. As we look at these graphs and these patterns, we can see if things are going well. For some lucky patients, we can see when things are going extremely well in the deep responses. And we see when things are not going so well, but not necessarily why, and that's where we have to put our thinking caps on and work it out very carefully. And PCR allowing us early detection of rises may allow us to change therapy at an earlier time point to re-establish good response.